So welcome everyone. Thank you for joining us today for our questions and experts session. My name is Bakun Adebimbo, and I'm the Manager of Operations with the Canadian Breast Cancer Network. So before we get started, I'd like to cover a couple of housekeeping items. So the session is being recorded and it will be available on our website for anyone who may have missed it or wants to rewatch it. The link for the video will be shared via email once the session is done and once it's been uploaded. I'd like to extend our sincere appreciation to our sponsors for this event, our gold sponsor, Viatris, our silver sponsors, Novartis and Amgen, and our bronze sponsors, Gilead, Merck, and Seagen. Our question and expert sessions are strictly dedicated to answering your questions, so there will be no presentation from our speaker, and she'll be answering live questions from participants, along with ones that have been pre-submitted. So please use the Q&A button that can be found either at the bottom or side of your screen to submit your questions, and we'll aim to take as many as we can. I'd now like to welcome our host for this session, Kathy Amendolia, Chair of the Board of the Canadian Breast Cancer Network.
Thank you, Bakun. Welcome everyone again, and thank you for joining us. I'm pleased to welcome Dr. Tina Su, who is joining us to answer all your questions about navigating a breast cancer diagnosis at an older age. Dr. Tina Su is a medical oncologist at the Ottawa Hospital Cancer Centre. She completed a CAMO CIHR-funded research fellowship in geriatric oncology, where she studied caregivers of older adults with cancer admitted to hospital. She is involved in developing the Canadian Network for Aging and Cancer, a grassroots initiative to connect clinicians, researchers, and educators across Canada interested in geriatric oncology, which aims to improve health outcomes for older adults with cancer in Canada. Dr. Su, thank you for joining us this afternoon. It's great to have you with us today.
Thank you so much for having me and for recognizing the importance of this issue.
Great. So while we wait for participants to start submitting their questions online or live, we'll get started with a few submitted questions in advance and perhaps get the conversation going. So when it comes to breast cancer diagnosis in older women, what age do you consider older?
Oh, that's a good one. And it's one that we tackle all the time. Certainly in studies, when we look at studies that are conducted specifically in older patients, many of them use the age cutoff of 65. Part of that is historical. I think that's where Medicare and people qualify for that. But I personally think, and I think a lot of us think, that 65 is so young. So I think, it's always hard to put an age cutoff. I would say we'd probably think of it 70 or above, or, certainly 80 and above for sure. But to be honest, when we think about it, I think age is just a number. It's an easy number for us to classify people, but really what it comes down to is health. I think that's what we're really getting at, is that as we get older, sometimes we've got other health issues as well. So no easy answer, but certainly that's usually kind of what we use in practice and in research.
Right. And that's true, because some countries view it as a different age than other countries. So too, nobody's really coming together with one set age. But as you just described, it all depends on the health of the person, and maybe age is just a little bit of a gauge as to how we're going to be helping these individuals. So with that in mind, what do you see are the unmet needs of individuals who are older when they're going through cancer diagnosis, in terms of health access, in terms of psychological support needs? What are the items that stand out the most?
Yeah. So I think where the challenge comes, and maybe why some people aren't getting the ideal overall treatment, is a couple things. I think one is that I mentioned using the age of 65 as, a lot of studies looking at patients over 65. And I'll tell you, the reason for that is really that a lot of the regular studies in which all our treatments are based on, those patients tend to be a lot younger. So you can imagine 65 to me isn't that old, but the average patient that's on studies is much younger. So it does, obviously cause issues when we're talking about, treatment recommendations and how do these treatments work in older patients. So I think that's an unmet need, because I think that one can only truly make an informed decision if you've got all the information. And I don't know that we have as strong data for some of our older patients. So I think that's part of it. I do see some of my older patients have other health issues that you need to be considered. And sometimes particularly my much older patients, sometimes they've lost some of their supports, maybe some of their loved ones, they may be widowed, and transportation can be an issue. So I think those are things that are really challenging for some of our older patients, that perhaps is a little bit less so with some of our younger patients.
And I would imagine that also mental health care is different at an older age, and some individuals, especially if they're facing being lonely and without support as you get older, that can happen. So that alone is something that is probably a little bit more prevalent in older individuals.
So I think certainly it is common. I think it's probably underdiagnosed, similar to other factors that can happen as we get older. I think that probably the biggest thing is that sometimes how older adults present with conditions such as depression and anxiety can be different from our younger counterparts. And so I think sometimes it's better recognized in younger patients than older patients. I'm not certain that it's necessarily more prevalent, but certainly I think that perhaps under recognized.
Okay, good. So I'm going to start with one of the questions that was pre-submitted. So how do the care and treatment plan for a patient over 65 with metastatic breast cancer differ from those for a younger patient with the same diagnosis?
So again, I'm gonna emphasize that 65 to me is still really young. But what I think I'll get at the heart of the question is how does it change if someone's older or younger? And I think that really depends a little bit on the patient, because certainly some patients who are 70, even some patients who are 80, may be very similar health-wise to someone who's younger. But I think what is different is a couple things. So as we get older, statistically, we are more likely to have other health issues that are important, either important to us or even important to how we might tolerate treatment or how the breast cancer might affect us. So for example, if someone's had a stroke or a heart attack before, that may influence what kind of treatments that someone may be, suggested to have, but it also may influence the likelihood of, patients living long enough to benefit from treatment. So many different factors from that perspective. And the other thing that I think is really important is that as we get older, sometimes we slow down, we might have other things that happen that may make us tolerate treatments less well. Not always, but sometimes those are things to consider. And I would say the last thing that's really important is that as we get older, as we have different life experiences, we may bring different things to the table, and things that are important to us when we're 50 may be different than things that are important to us when we're 80. They may not be, but they might be. And what I mean by that is someone, many patients that I talk to, when I talk about what's important to them, often it's longevity. They want to live as long as possible. When I talk to a patient who's in their 80s, some of my patients, that's really important to them, to live as long as possible. But sometimes what it is quality of life. What's most important to them is to be able to take care of themselves, to be able to think, to be able to, I had a lady last week who told me what was important to her was to be able to play golf and socialize. Mm-hmm. That was what was most important to her. It wasn't living as long as possible. It was really being able to enjoy life. So I think those questions become more pertinent. I think there's no reason those are important to younger patients, but if we're talking about averages, I think as patients get older, they tend to have other preferences and values that become more prevalent.
Great. And in terms of management for any treatment that patients are on, I don't know, again, if they're over 65, over 70, let's just call them older patients. Do you find that they need better management? Are their symptoms more difficult to manage? Is there a difference between an older person and a younger person on the same treatment plan, let's say tamoxifen or any, not tamoxifen, but any AI that they may be given? How do they manage, in terms of making sure they're being compliant, especially if they have comorbidities and they're also taking other drugs?
Sure. So I'm going to group it into two different types of treatments because and I'm going to focus on systemic therapy, although I would say we could, certainly generalize this as surgery and radiation. But from systemic therapy perspective, I think that some drugs, like when we talk about chemotherapy, there can be at least a concern of more toxicity, or maybe I would say more the implications. So, someone may have the same side effects, that they may more have troubles, or it may have implications on their ability to, take care of themselves or get dressed or get around their house, or to their cognition. So I think that things that we have to consider is, one, we have to do a really good assessment to see what is the risks for that patient. And beyond just age, like what is their health like, and what is their function, and what are their values and preferences. So I do think things like systemic therapy, some patients do need either modification or they need to be monitored more closely. But in terms of things, interestingly, I will say, in terms of endocrine therapy, in my experience, I actually find that older women statistically tend to do better. And that I always tell my patients, especially the vasomotor symptoms, so things like hot flashes, menopausal symptoms, I actually find a lot of my older patients tolerate it really well, and they often don't have it. And maybe that's because their menopause was so long ago compared to my young patients who are just going through it or being put into menopause because of our treatments.
Okay.
In terms of, you mentioned, sorry, I forgot, you mentioned compliance.
Yes.
So I check for cognition. I ask patients how, do they have any troubles with medications? Usually, if there is a concern about cognition and compliance, I really, really like blister packs. So where the pharmacy will put them into little bubble packs so that patients can actually physically see what's happening there. And sometimes I rely on caregivers or family members to help with that as well. We do other little tricks like, having like an alarm or something for people to remember. So those types of things for sure.
Great, thank you. I'm going to pass it over to Bakun. Bakun, maybe you can ask some live questions.
For sure. So we have someone asking about hormone treatment for lobular breast cancer. They said that they're a 78-year-old. So just wondering, can you speak a little bit more about that? Is that kind of the best treatment for them? What can they be expecting at that age?
Yeah, so I think, so I just popped up the question and answer as well. So I see there's a little bit more to that. I think that in terms of lobular breast cancers, most of them presume, we're making a couple of assumptions here, but assuming that this is a hormone, very typical or classical lobular breast cancer, these tend to be hormone sensitive, HER2 negative breast cancers, which means probably the biggest bang for the buck, or what's really important, is endocrine therapy. Now, there's certainly different ways for people, or different strategies for endocrine therapy that can include either tamoxifen and aromatase inhibitors, or just aromatase inhibitors. And how I choose really depends on my patient's comorbidities. So what other health issues do they have? Do you already have thin bones? Do you have issues with blood clots in the past? So those factors do play into it. I would also say that sometimes it comes down to what's really important to them. If a patient really has a lot of arthritis and mobility is a concern, and what they say is most important to them is for them to be able to continue to walk independently, continue to get up and down those stairs, then I might give them a drug like tamoxifen, which I find is very, it's an old drug, but old doesn't mean bad. It works really well. And so I really like it a lot. But I would say there's a lot of different patient factors. So obviously, I encourage you to talk to your own oncologist. I'm sure that they'll have some thoughts and they'll know you a little bit better. But both of those. And for chemo, in general, chemo depends on a number of factors. Lobular breast cancers in general tend not to respond as well to chemotherapy. And so the risk benefit isn't, chemo has more side effects and less benefit. But it really comes down to a discussion with yourself and your oncologist about what's important to you. And I can't stress that enough. It depends on your health, and it really depends on what's important to you and how much do you want to do. You want to do every little thing to try and live as long as possible, or is it to live as well as possible and not have to go through chemotherapy?
Sure. And to kind of follow up on that, like how would a patient bring up this conversation with their healthcare provider? Like, is it that the healthcare provider would see that they're at an older age and kind of have that conversation, or if the patient needed to talk about different comorbidities, frail bones, like would it be the onus be on the patient themselves to bring up that conversation?
I think in terms of general health, other things like other health conditions, I think that really should be up on the physician. I mean, that's something we do routinely. I think what is important to bring up is a couple of things, is that things that are important to you. So sometimes I think when physicians are really busy, sometimes we should be, but I'll admit sometimes we don't always ask what's really important to you. And particularly if you're having a cancer that's been removed, you have a choice. And so you have a choice. So you need to understand what are the pros and cons of this, and you can ask that. And if you're someone who thinks that the most important thing to you is to do everything possible, make sure that doctor knows that. Because I do, what I do say, and I feel embarrassed to say this, but I think as patients get older, sometimes some physicians, I won't say all physicians, will tend to have some more of a bias. So we presume there's a presumption made that as you get older, well, certainly you don't want to have chemotherapy, or certainly living as well as possible must be much more important than living as long as possible. And on average, that probably is true. But I think it's important that I always say, there are some studies showing that, and I say, you don't know unless you ask. And so I think sometimes people don't ask, and I think that maybe that's where I would say maybe it's important for you to bring that up.
For sure. And yeah, as you said, so the person had asked kind of like a two-part question. So the second part is about follow-up tests. I know you're not a surgical oncologist, but just to kind of maybe keep it general, like is the approach to follow-up tests and surveillance tests different between older patients and younger patients?
Not in general. I will add a little caveat to that. So in general, the follow-up tests that we do, I always tell people it's a history and physical exam, meaning I ask you how you're doing, looking for symptoms, and I examine you. So looking at your breasts, if you had a mastectomy, then making sure certainly there's nothing in the skin. So I think that's really important. I would say that's generally important in all of my patients, regardless of age. The only test we do as a routine, meaning if everything's great and you're feeling well, is a mammogram, typically speaking. I'm not going to get into other parts, but I'm just going to say mammogram in general, we would do. The only thing I would say that's different when you talk about older patients, and I wouldn't say it would be age related, it would really be health related and life expectancy related, is the point of having a mammogram, just like having mammograms in general when you don't have cancer, is to look for something when it's really early so it doesn't develop into a cancer down the line. And usually when we're talking about the benefit of screening, we're talking about a 10-year timeline. So if you start to have a lot of other health issues where, you might have troubles like getting dressed or taking a shower by yourself, where things might indicate that things may not be as long as that, then it's worthwhile. Sometimes I have conversations with patients about risks and benefits, and there really are risks to doing tests. We all think that doing a test is a great thing, but sometimes you find things, and then the question is, what do you do about it? The best example I can give is prostate cancer. So we know that many men have prostate cancer. It's really common, but a lot of men die with prostate cancer, not of prostate cancer. And that's not everybody, but that's the case. And similarly with breast cancer, if you start to have other health issues, like if you had a stroke or something else, finding a little really early breast cancer that's so small that no one can feel it and doing something about it may not impact either how well you live or how long you live. But I think there's an impetus that when we know about something, people feel really uncomfortable not doing something about it. So sometimes in those situations, I really advocate for just physical exam, because if it's something I can feel or you can feel, it's probably more clinically significant than something I can only see on a mammogram.
For sure. Thank you for that. I'll go back to Kathy with the pre-submitted questions.
Right. So before I start the pre-submitted questions, in terms of patient voice at that age group, the age group that we're still trying to define, do you think that there is a strong advocacy within a person as they get older? Do you think they shy away from coming forward and asking for help? Do they need to come in with a support, a caregiver mostly? How do you find that age group manages their own health at that in older age setting?
Yeah, that's a great question. I'm really glad you asked that. For two reasons. I think one, I'm always looking for people to, trying to get older adults to advocate for themselves. I will say in general, I mean, it varies. And again, this, even talking about younger patients or a patient with triple negative, everyone, people are different, and we know that. But in general, I'll notice that, certainly, and I think this is the way that people have been raised, right? If you are 80 years old, you have different life experiences. You might have, had different things growing up, and your expectations of health may be different than someone who's currently in their 50s or even in their 60s now. And so right now, some of my older patients, they may, there's a differences sometimes in their advocacy, sometimes in their health decisions. Sometimes they may be more likely to do, well, I don't know what to do. What would you do, doctor? Right. Whereas some of my younger patients might really have a very, really want to make their own decisions. And so those things can change. I do find that some of my older patients are less involved, or at least maybe less vocal in advocacy than some of my younger patients, for sure. I would say I would encourage anyone who's on this, who, falls into that category and is interested, I think, please, add your voice. I think it's such an important voice to be heard. I also think part of the issue is that sometimes as people get older, sometimes they have other health issues, they're more frail, and sometimes it takes a lot of energies to, advocate. Sometimes the level of education some of my patients may have had at that time, which was very normal, certainly at that time, may be very different than some of my patients now. And so the other thing I always tell people, when I talk to other healthcare providers, is I think the patients who are in their 80s right now versus their patients who are now just like in their 60s, who are going to be the 80s, are going to be very different when we treat them. Because I think your demand, what those people grew up with, what people are going to demand, is going to be very different. So, there's all of those types of things that can happen. Do I think that people should come with someone else? To be honest, I think every patient, regardless of age, should come with someone else to one of these appointments. They're jam-packed for consults, and we talk about so much stuff. It's never a bad idea to have a second pair of ears. What I do think is really important, though, is that we acknowledge that at the end of the day, our patient is our patient. So regardless of what their family thinks, unless they invite their family, like they're the type of person who says, I want my family to make the decision, I think we just do want to keep front and center that it is, their health at the end of the day. And I think most families are very respectful of that, but sometimes you just have to jig the dynamics a little bit.
It's true. You're right. It is a generational, and as the generations move on, there's a different way of approaching things as the next generation comes along. So my comment is, how do we address those that are in their 80s right now and not go and are not where the 60-year-olds will be at 80? And how do we come together to build on what we already know that is missing within that age group?
Well, I think one thing first is for us to so this is a good start in terms of recognizing that, that older adults should have a voice and that older adult health is important. And I will say I've noticed a difference even from the time that I trained to now, that there is increasing recognition of the importance of, assessing older adults perhaps slightly differently. So I think that we are showing cultural changes, and I think that's really important. I think we need to, when we do surveys and when we do things about needs assessments, we have to be pointed and very intentional, I guess is a good word, about asking some of our older patients and frailer patients, because maybe they're people who, may not have access to the internet, or may not be on Twitter or on whatever. So being really intentional about the way that we try and recruit for our answers, potentially interviews. So things that sometimes people share life experiences. There are different ways for us to collect data to make sure they're not left behind. I think that's really, really important. And I would also think the other thing is that sometimes having someone who's maybe their role is to really represent older and less fit patients, because I think that sometimes I think about this when I do studies, and I think about how do we get those patients who aren't already on studies, the patients who have less energy or less, don't want to put out their family members to come for that. How do we reach them? And I think what we need someone to be their voice. They may not be at the table, but we need to make sure that we get their viewpoint.
Very good. So I'm going to go to the questions now that were submitted.
Okay.
So this question, how do breast cancer patients 50 years and older with dense breasts get additional screening beyond mammograms in Toronto? So I guess they're asking, what do they need to do in order to ensure that they get those tests?
Yeah. So, first of all, I don't work in Toronto. And I will say when I did train in Toronto, but when I trained in Toronto, additional screening in women with dense breasts was not a thing. So I actually don't know what they do in Toronto. What I can speak to is that there is variability in what people do, but I'll tell you why there's variability. Although I'm not a radiologist, so this is not my huge area of expertise, but we have had meetings about this. Is that so? We know that women with dense breasts we're less likely to catch smaller lesions. So we know that. The question is, what do you do about it? And that's really, I think, where there's still a gap in knowledge. So we know that things like MRI can increase the sensitivity of catching things, but we don't know that going to change outcomes, because the studies show that they pick up things earlier, but it doesn't show. Ultimately, what we want you to do better by picking something up. We actually here in Ottawa, we also don't do MRIs as additional screening. At the Ottawa Hospital, they offer ultrasounds every couple of years, breast ultrasounds. But I will give you an example. There are hospitals in Ottawa that don't do that. And what that means is that there's no consensus, and that as far as I'm aware, I don't think there's good data to show that is better. I think that we need that, and we need those studies to show, because obviously at the end of the day, what do we want? We want people to have better outcomes, that by intervening on something that we do, that you do better. So it's a bit of a long-winded question. I would also refer you to, I think there was an Ask the Expert session with Dr. Jean Seeley, who is a radiologist here in Ottawa. And I believe that she did talk a little bit about dense breasts as well.
Yes.
Yeah.
So another question I have is, this woman writes, I'm a 71-year-old female and I underwent a bilateral mastectomy. Is it really necessary to treat the stage 1 breast cancer, which had clear margins when both breasts are now gone?
That's a really great question. So I think the question I want to just clarify the question for you, just to get at what you're asking. So it's important to recognize that surgery and radiation is to decrease the chance of the breast cancer coming back in the area you had surgery. So we're talking about trying to decrease what's called a local recurrence. Things like hormonal therapy, like tamoxifen, and aromatase inhibitor, which is most likely what a person with a stage 1 breast cancer would have been offered, presuming it's hormone sensitive. Obviously, if it's triple negative, it'd be different. That's really to decrease the chance of cancer spreading somewhere else. So coming back somewhere else, like the bones or the liver or the lungs. So they're really, even though you had a mastectomy, that's actually very different what they're trying to accomplish than something like drug treatment. So but then the second question is, do you have to have it? And I was going to say the answer is no, because you have a choice. And the reason you have a choice is that for most patients with a stage 1 breast cancer, you probably have a really high cure rate. And that means with surgery alone, a lot of people are cured. Obviously, again, depends on if you're HER2 positive, endocrine or not. And that means we benefit some people. So some people will have a benefit and a lot of people won't. So you get to choose. Is it important to you? Do you want, do you feel comfortable just kind of seeing how things are, or do you want to take something to improve your chances that it won't come back?
So, having said all this, do they do genomic testing, on somebody who is 71, where they're trying to decide if they're going to give them treatment or not? Yes, ultimately it's up to the patient. And I guess the risk factor is what's going to make that decision. And, but younger people are in some parts of our country going through genomic testing, and then that kind of gives them an idea of what to do and what plan to follow.
Yeah, so I don't think that there's a difference whether you're younger or older to have genomic testing. I actually think that more has to do with with a clinician practice than anything. And I'll tell you the way that I practice. I think that genomic testing is great. It saves a lot of people from needless chemotherapy. But I think that it depends, your benefit of chemotherapy depends on your risk. So it depends on, the tumor characteristics. So that does still play into it. We know that. It also depends on whether you can tolerate what kind of treatment. Genomic testing is really for chemotherapy. So we're really talking about, can you tolerate chemotherapy? And the third thing I always ask my patients is, do you want to have chemotherapy? Would you be willing to take chemotherapy or not? Because there are some people that come in and you could tell them there's, X amount of benefit, and they said, no way in heck am I going to take chemotherapy. And there's other people who are really, concerned. They feel they want to have done everything. They really want chemotherapy. So I think you have to understand that too, because a genomic test is really to help someone make a better decision. But if you've already made a decision, like, I don't want to have chemotherapy, I'm not fit enough for chemotherapy, various things, there's no point in doing genomic testing in that circumstance. So for me, I do genomic testing, but I assess a patient first. So from that perspective, I do that. And then it doesn't matter about age. Age plays into some of those factors I talked about. So, benefit from treatment, tolerance of treatment. I guess the only other thing I would say is life expectancy. So if you have, I always tell people, not in a bad way, but like certainly if you're 80, the chances of you being around in 10 years is a little more murky than if you're 50. So there is a component of age in there in terms of likelihood of benefit, because if you have something else happen, then it doesn't really matter what happens with the breast cancer. So would I say I think genomic testing should be considered for patients who are older and younger, but it depends on a number of factors.
Thank you. Bakun, let's take some live questions.
Sure. So you could, just to kind of follow up on what you're speaking about, so you could, with tests, and you had spoken about kind of testing a patient's, if their patient is fit for chemo. So are there specific tests that patients can do, whether by themselves or their caregivers or with like their physicians, to test their fit? Like if they are fit, like how would someone determine whether they're fit for chemo? Or is it just like a personal, like they hear what the side effects are and then they're like, oh no, I don't think I can tolerate that?
So I think there's two parts. I think part of it is a clinical assessment of fitness.
Mm-hmm.
So that includes things, certainly there's the things that, every physician does, but there's certainly other things that one might do. So certainly, for example, things that I look at are, I do a cognitive screen. I ask about things about, can you get dressed by yourself? Can you get to the bathroom? Can you take a shower?
Mm-hmm.
Things that maybe some of the physicians may or may not do. Do you cook? What's your, are you able to make your meals? How do you get place to place? So those things can play into fitness. I do walk tests. There's also something called a chemotherapy toxicity calculator. There are two tools, but one we use a little bit more often than the other, which is the Cancer and Aging Research Group. And there's actually one specifically for patients with breast cancer, in patients who've had surgery or are eligible for surgery, that type of thing. So I use those types of things to look into kind of just from a medical perspective. From a perspective of, can I have chemotherapy? I mean, I think there's a psychological perspective as well.
Mm-hmm.
I would say in general, most of my patients, if you ask, aren't like super keen to have chemotherapy, but some will. So I think whether you can, that's an internal decision about how people feel. I do generally help with that assessment of, I assessed you and I think I tell my patients, I would only offer you chemo if I thought you could, tolerate it.
Mm-hmm.
Now, then the decision about whether they psychologically can do that, that's up to them. So I think we do help people from that, but I have to admit, my interest is older patients and I do a little bit more of a detailed assessment. But those are things that people can think about.
For sure. And then the submitted question that we have is also on tests. So this person's asking, should older patients request a bone density test to be a part of their follow-up plan?
So I think it depends on what the context is. So if we're talking about, should older patients on a aromatase inhibitor be having a bone density as part of their follow-up plan? The answer is yes. You should. So I always do one baseline or even just maybe a few months later. And then when you have another test, depends on what that first test looks like. So if your bones are really strong, you probably don't need another bone density for a couple of years, 2 to 3 years. If you're kind of in between, you might need some medications to strengthen your bones, or at least minimum, I would do a bone density on an annual basis if the bones are not as strong. But like if you're on tamoxifen is actually quite good for your bones. So I don't do bone densities in those because it's not a side effect of treatment. And so I don't think every patient with breast cancer needs a bone density. It really depends on if it's a side effect of the treatment.
Oh, I got it. Back to you, Kathy.
Yeah. So let's discuss a little bit about nutrition and exercise. Let's start with exercise. How do we ensure that older patients, and to your point, somebody from different decades is not used to doing what, a younger person is used to doing now. Like exercise has been a big thing with certain age groups, and it didn't used to be. So how do we ensure that patients are provided the best information for them to understand the benefits of exercise at an older age?
Oh, that's a really difficult question. I mean, I do talk about exercise with many of my patients, particularly in the context when people are asking, sometimes people ask, well, what else can I do to decrease my risk of breast cancer? And so certainly there are guidelines about exercise in terms of cardiovascular exercise. If someone's on an aromatase inhibitor, which can affect the bone, certainly weight-bearing exercises are very important. I'm not an exercise physiologist, so I wouldn't say that I have been and as a physician, we're not trained in giving advice about exercise. The best thing I heard from a family doctor or someone was to write a prescription and write an actual prescription, so it looks like an actual prescription, and give it to someone, and this is what you should do. So that's actually the best data that I know about. If someone's interested in hearing more about exercise, Karen Mustian, Mustian, is an exercise. She does exercise, and she works at the University of Rochester, and she's interested in older adults with cancer. So she does a lot of stuff in terms of exercise. She has told me, like, you do have to give people guidance. And one of the things I tend to do is sometimes we talk about, little steps. You don't tell someone to run a marathon right away. You give them steps to kind of get there. And similarly, I kind of tell people, start with 5 minutes a day or 10 minutes a day. If that's all you can do, kind of do that on a daily basis. And once you can do that, then you can start to increase it. So I kind of try personally, as an oncologist and not an exercise physiologist, I really try and help people. I think change is hard, and I think you have to make change doable for people. And that's really my philosophy, is to pick something that someone can say, okay, I can do that. That's not so hard. And then kind of build from there.
Great. And what about nutrition? I do realize that as you get older, sometimes your appetite is not the way it used to be. I think that especially older patients, they seem to not have that, and desire to eat as much. Is that a problem when you're especially being on a treatment?
I do notice that as well for some older patients. I think the question is trying to determine the cause of it. You mentioned mental health earlier, about is this a matter of just, they're not hungry? Sometimes, naturally some people aren't as hungry as they older, but is this a manifestation of something else? Like people are depressed or anxious and other things like that. Is a side effect of your treatment. So I think those are important to identify. So really trying to figure out the cause of that. Outside of that, do I worry about it? I really worry when people are losing weight, to be honest. Some of the treatments, particularly if we're talking about chemotherapy, across the board, people often will have changes in taste and changes in their appetite. So where do I get really concerned is maybe when people are losing weight, and that really worries me. Other than that, what I do spend a lot of time talking to people about, again, is just like this eating, quite regularly, eating very frequently, especially if they're eating less than usual. We often will have a referral to a dietitian if people are having weight changes from that perspective. So.
Great. So I'm going to go to a pre-submitted question now. Are most patient cancer diagnosed in diagnosis? Are most Are most patient cancer diagnoses in older women a first-time diagnosis or a recurrence? I guess the question is, at an older age, what do you get? The recurrence, or do you have a first-time diagnosis?
Yeah, I would say actually the vast majority of patients I see are a first diagnosis. You do have a higher chance of having a recurrence because if you've had, if you live long ago, I always tell people if you live long enough, half of people will get cancer in their lifetime, and we know that. And the other thing is you may get another cancer completely unrelated to your breast cancer. But I would say the majority of ones are first time diagnoses, and I would say that's because in terms of breast cancer, we have a very high cure rate. So for breast cancer, typically it's a first-time diagnosis rather than a recurrence, though obviously we do see the latter.
And when is the cutoff for doing a mammogram?
Are you talking about for people who have never had breast cancer or people who have never had breast cancer? So the recommendations, so the Canadian Family Physicians and the Ontario screening program, I think stops at age 75. I think that's rather, personally speaking, I think is rather arbitrary. I understand the reason it happens, and that's because all the screening studies, I think unilaterally, I think patients were cut off at 74 or 75. So that's what happens. Like you will fall out of a screening program. That doesn't mean that you can't continue screening, but your family doctor or someone has to order it. I think it's reasonable personally to consider continue screening as long as your health is good and this comes down to life expectancy again. So I think if you start to have a lot of other health problems or you're having troubles like with dressing or bathing and things like that, then I think, it's reasonable to consider not doing breast mammograms anymore and just only bring something to attention if there's something palpable, because you really do, again, as I said before, you run the risk that you do find something that, inherently everybody wants to do something about, and inherently I'm sure you want to do something about, but may or may not benefit you in the long run.
Great, thank you. The next question. Why can't oncologists openly discuss aging and cancer, especially when they do research papers on de-escalating medications to seniors and adverse effects? Is it a taboo?
So very interesting question. I don't think that they can't. I think that many oncologists don't talk about aging and cancer. And I wasn't certain about the research papers part, but I'll try my best to answer. So do I think, I don't think oncologists talk enough about it. There's actually a study looking at the benefit of what's called geriatric assessment, which is basically a more detailed assessment versus just usual care. And they actually found that people who had geriatric assessment were more likely to talk about aging related concerns, which I think is what this question is about. But why do I think people don't do it? I think that people are very busy. We have limited amount of time. We're certainly not lacking for patients. I'm sure as the Canadian Breast Cancer Network, there's a lot of patients with breast cancer. And I think that within a time period, we also want to talk about the cancer stuff. I mean, that's why you come and see the oncologist, is sometimes to talk about the cancer. So we don't want to short shrift you from that perspective either. So I think it's not that they can't, and I don't think it's taboo. I think it's just that people don't, in the time that they have, they're focused on, the cancer stuff. I will talk about, I think the second question, I'm not 100% sure about, but I think what it's talking about is why oncologists don't, do deprescribing, which is something we sometimes think about about stopping unnecessary medications or medications there's interactions. I think if I had to ask the average oncologist why they don't do that, I would say probably a lack of knowledge or feeling that they really feel very comfortable with it. Sometimes these drugs are prescribed by other people, so they might not feel that it's really up to them to deprescribe that. And maybe the third reason, again, coming to time. So if we're going to stop your medication, I got to tell you why I recommend we stop your medication or why we should stop it. So I think that's a combination of things that people just don't really touch upon them.
Great. I have another question. Are there more benefits of alternative health treatments for older patients than for our younger counterparts?
So interesting question. I actually don't know the answer to that. I've not read anything. I've certainly read studies looking at, we know alternative health treatments and complementary and alternative medication use is very prevalent in all patients, but even in older patients with cancer. I have not read anything to suggest that there's differential effects in older versus younger patients.
Okay. So Bakun, do you have any questions that might have come your way?
Well, I just kind of want to follow up on what you were talking about earlier with side effects. Are the side effects for like hormone treatments, for example, like do you see those manifesting differently in older patients versus younger patients, or is kind of similar? So like the management for it would be similar, or is there a difference because of the age?
So as I said before, I think the biggest difference I tend to notice is that so a couple, I would say the symptoms related to menopause I find tend to be less in my older patients. That doesn't mean my older patients can't have hot flashes, but I would say compared to my younger patients, it seems to be less bothersome and less for on average. I would say aches and pains probably bother more of my older patients because they tend to have more arthritis than some of my younger patients. And I think the implications of having low bone density is higher because they're more likely to have a fall and break something. So I don't think that the management I find tends to be different, but perhaps what's important, what are the side effects that seem to bother them more might be different. And certainly the threshold that someone might have to stop their treatments. So, and that really comes down to both risk and also due to preferences. So someone who is very young may be incredibly motivated to stay on their medication because they really, want to live as long as possible. I find that, when people have side effects, I think we go back to, I talk to them and say, hey, this is, a medication that you can take. You've already had your cancer taken out. This is your risk of coming back. This is how many people benefit it. Now that you've had a chance to be on the medicines, is it still something that you want to take or not? So I think people have to recognize they have choices, and sometimes we just make different decisions, and that might be influenced by our life experiences.
And I just want to go back to when we were talking about comorbidities. Are there certain comorbidities that you see coming up more for older patients?
For sure. I mean, I think I'm actually sure. I bet you some of our audience could probably name these as well. But certainly, as we get older, things that we do see is more people have high blood pressure, cholesterol issues, diabetes, other things, arthritis we mentioned, and osteoporosis. I would say those are things that we see that are more common and also probably important in our decisions. I mean, heart disease as well, obviously. Heart disease, although cancer, I always like to tell my colleagues, cancer is, one of our #1 killers in Canada, but so is heart disease and stroke. So those types of things we also see more frequently as we get older. And probably the other one that we do see more, thankfully not everybody, would be memory issues. So cognition, things like dementia can be more often as we get older.
And are any of these like exacerbated by the cancer?
So I'd say not by the cancer, not typically. I would say but cancer treatment or having cancer may affect how we look at or manage things. So it goes both ways. So sometimes if you have comorbidities, that might affect what I decide to give you, or my strength of recommendation. So for example, if you have osteoporosis, I might not want to give you an aromatase inhibitor because I'd be worried that maybe it's not so good for your bones. If you have a history of falls already, I might not want to give you a chemotherapy that's going to cause issues with your feeling in your feet. So it can affect the cancer treatment from that perspective. Cancer treatment can also affect some of your comorbidities, or in terms of how that goes, or even like if you started to be very unwell and you had cancer and you were towards the end, we may say, well, on the idea of deprescribing, we might just say, well, it's probably not as important that your diabetic control is very, very tight, or so you might be able to eat better food and not have to be on a strict diabetic diet. So it can affect things both ways, in different ways.
Kathy, back to you.
Sure. So if we talk about advocating for themselves at an older age, we see often where the children of these older patients come with their loved ones, right? And oftentimes, I think you would agree, the patient is left by not feeling she could express, because the children ultimately want their mom to live forever. So how do you balance those decisions when you have an older person who is like, okay, I have a doctor in front of me and I have my children who are trying to plan this for me? How do we teach elderly people to put in their voice when everything around them is trying to solve the problem?
I don't know about teaching. I'll have to think about that. But I do think the onus is on, like, if I do a good job, I have to balance that, what's going on in the room, right? So it's making sure that at the end of the day, I have to remember who's my patient, and I have to look at my patient. So even if someone's talking over them, I always give, many people will probably notice, I know you're not in the same room as me, but my first question is to my patient. They get first go at it. Family members are allowed to add. And I always say that, I want to hear from you first. If your family members want to add something in, that's totally fine. Or if someone says something, if I have an older patient who's very tired and isn't communicating as well, I might just say, hey, we're going to talk about you, but we're going to talk about it right in front of you. If you have something that you disagree with that your loved one says about you, you pipe up. Or I might kind of direct and make sure, invite them into the questions and kind of say, do you agree with what's been said? Do you disagree? So I think there is a bit of an art, and that's more a communication art. That's not really, I understand that's not really teaching someone to do that, but that's really, I think what's really important is to continue to remember who our patient is and to really balance that. And as you said, I really liked how you mentioned is at the end of the day, what I remember is that loved one is really, they love their parent or they love their loved one. That's why they're being, vocal and advocating. And so I'm not trying to dismiss their concerns. I just want to make sure I also hear what my patient says as well. The last thing I could say, I don't usually do this, but I guess if you're really concerned that they're not getting their voice heard or something, sometimes you can invite someone out during the physical exam and then, certainly ask them to make sure, like if they want to talk with their family members not there. So certainly that is an option. I haven't really found that I've had to do that as much, but certainly that's something I would think about if I felt, for example, I couldn't get control the flow of the conversation because someone was being too demanding, then maybe that's something I would consider.
That's a wonderful answer. But the problem comes that there aren't many of you across our country. So for our listeners listening to this, it would be fantastic if each and every one of us ideally would be able to sit down with somebody who is, an expert or, interested and passionate about caring for older individuals. So what would you say to our listeners and individuals who come to CBCN? How can they navigate to a professional to get their answers when they're living in rural communities, when they're not living at close by a cancer center?
So what I will say is I think that when you have time when you see your oncologist or your doctor, definitely feel empowered that you can ask questions. I do know that some patients feel that, oh, my doctor's so busy, I don't want to ask any questions. I'm like, no, that's what your doctor's there for. I mean, yes, you can. I commend people who look for other things and, try and do their own stuff. But I mean, that's kind of what we're here for. Like, if you have a question, you should feel that you should be able to ask it. Now, sometimes things are really busy. So, and sometimes I know some of my patients forget, right? It's the moment the doctor walks into the room, you've forgotten what it was that you wanted to ask. You're like, oh gosh. So I encourage people to write down their questions. I think that's really important. I do think places like, if you are really motivated to look at places like CBCN or, the Canadian Breast Cancer Society or the Canadian Cancer Society and stuff, I think those are really important, those are good, but I don't think that we should just rely on that, because, and I say that only because the people that are at, these seminars and stuff are probably a little bit more, are more, they will more likely to self-advocate for themselves. I think better technology, probably better education. So I think we don't want to leave anyone behind as well. So I think that we also just need to, I want to give them people the skills, but I also think the onus is on us as well as healthcare providers. And yes, I understand that people are different, but you know what that tells me? It means that we need to teach, like, that's why I'm passionate about education and why I do train residents and stuff, is to make sure that who we are training are going to be really good doctors for you guys. So I think that's really important. So if we're not doing a good enough job, we need to do better.
I'm gonna go to a submitted question. It reads, I am a 72-year-old female who had a radical mastectomy in 2014 due to invasive lobular cancer. I also have the CHEK2 gene. I received chemo followed by axillary node dissection, where one half of the nodes removed were still cancerous. They probably still had cancer. I then had radiation and I just had a biopsy recently. If the biopsy is positive, what are my options this time? I guess you're not their doctor and it's very hard for you to answer this, but if you can just respond to you know,
Sure.
the basic essence.
Yeah, so I think it obviously, yeah. So I think it depends on where the biopsy and recurrence is. So the biopsy, because I could see this being in one of two places. It's either in the armpit, in the axilla, or in the chest wall, because they had a mastectomy. So it depends a little bit on where it is. And ultimately, at the end of the day, it depends on if they can cut it out or not. Often recurrences in the chest wall are much more difficult because they're very close to ribs and skin and things like that. So if surgery is an option, usually we would do surgery first. That would be our preference. If it's not an option, sometimes if we can shrink the cancer, we might treat so you said you had lobular breast cancer, so probably we would talk about endocrine therapy if this is a hormone sensitive breast cancer. And sometimes if that's not the case, then we might do some, you had radiation, so probably less likely to do radiation because if you had 2014, so we're talking about 9 years, sometimes the side effects of radiation can accumulate. So it'd be less likely, but it just depends on where the location is and how much radiation you got to the area previously.
Okay, so next question. What are your best tips to help recurrence and long survivorship?
Yeah, so I have two things, one cancer related and one not cancer related. So in terms of, some people ask me about what can I do? Often people ask me, what can I do to decrease my chance of breast cancer coming back? So things I talk about, there's good data about exercise. So making sure that you're moving, getting 150 minutes of cardiovascular exercise a week. So getting your heart rate up. Sometimes one of my colleagues says you have to just enough to perspire. So that's part. And then alcohol in moderation. So probably for women, it's probably no more than 1 to 2 per alcoholic drinks per week. And then good overall diet. But really what that relates to is not being overweight. So eating well, so not being overweight. So so there is data to suggest that the combination of those three can decrease the chance of breast cancer recurrence. My other part, though, that I talk about is that for many of my patients, some of them have lower risk cancers, or some of them are doing very, very well. So in that case, when we're looking at the next 5 or 10 years, when I'm talking about especially my older patients, because this is what the session is about, really, we talked about other risks to life. So we're talking about things like heart attack and stroke. So what I think is really important is for people to have good primary health care. So if you're lucky enough to have a family doctor, and I know that's not everybody, so I apologize, but I always encourage people to go back to their family doctors, because when people are going through breast cancer treatment or any cancer treatment, they kind of feel like they're being seen so often. They see us, they kind of feel like they're getting good care, and they're getting good cancer care. But what's really important, when I think about preventing something bad, happening down the line, is getting your blood pressure checked and checking for diabetes, getting all of that stuff checked is really important. Primary prevention is excellent. So I think those are things that I tell my patients. I encourage all my patients to go back to their primary care providers to make sure that they're getting the best health care, because sometimes at the end of the day, it's not always the breast cancer that becomes an issue. It can be something else.
Great. Bakun, how about some questions?
Sure. So I'm just wanting to go back to the idea of being fit for chemo. And this is taken into account that you're not a naturopath or a surgical or radio oncologist. But if it's found that maybe the patient isn't maybe ideal for them to take chemo, like what are the other options in terms of treatments that like that's not like alternative treatments? Like is surgery or radiotherapy, like are they on that same level of chemo where it's kind of like it has those same concerns, or is it like, okay, I'm seeing that this patient might not be fit for chemo, so the surgery alone is good enough, or the radiotherapy?
Yeah. So obviously it depends a little bit on the phenotype of the receptor status of the
Yeah.
cancer to say what's needed.
Yeah.
The good thing I will say is that breast cancer surgery is not the same as some of the, so I treat colon cancers and pancreatic cancers and stomach cancers. Those surgeries are obviously much more difficult than breast cancer surgery. So even some of my patients who aren't as fit can still have breast cancer surgery. And surgery is, at the end of the day, surgery, I don't like to say this because I'm not a surgeon, but I'll give them credit. Surgery is very important and it cures cancer. So surgery is really an important part of the treatment. So I encourage it. Just because you can't have chemo doesn't mean you can't have surgery. Just because you're not fit enough for chemo doesn't mean you can't have surgery. So it depends, obviously, there are many factors here that go into play. Sometimes, and there are sometimes that patients who because of their own personal preferences or discussion with the surgeon, sometimes if they have a hormone sensitive breast cancer, people will get what's called primary endocrine therapy. So they get treatment not with surgery, but with hormonal treatment. And I've done that even in people who are not as well, people who have had, dementia. I've had people who are frail. So generally, the good thing is it's a very well tolerated treatment. So those are different options. Now, I do think that people should be counseled, and we really need to look at people to understand, if they are, can have surgery, or if this is just what they want. There are different factors, but certainly those are options for people who, might not be a candidate for chemotherapy.
Mhm. And if there are comorbidities and, the patients, as you've kind of stressed throughout this session, the patient always has a choice. So if there's a case where a patient chooses, no chemo, no surgery, no radiation therapy, like what happens in that case? Is it that because of the other comorbidity they have, they kind of just treat that and leave the cancer? Like what happens in those scenarios?
So I have had some patients. I have to admit, it hasn't always been older patients. Have had some younger patients who've chosen not to have any traditional therapies. They might have gone somewhere else. It really depends, also often down to the biology of the cancer, and also what those comorbidities are. So and how fast the cancer is. We've all seen some people who come in with very large cancers that have probably been, when you talk to them, they're what we call neglected breasts, where people might not have presented. Either they're scared of the healthcare system, not through any really fault to their own, but they might have had it for quite a long time. So when you talk to them, they said, "Oh, I've had this for 5 years or 6 years." It really depends on what the situation is as to how symptomatic a patient will become and what we would do about that. Certainly, because of symptoms, we often encourage people to have some sort of local treatments. Like if they're having like discharge or pain, radiation is great. But at the end of the day, as you said, we're certainly going to do something that's consistent with what the patient wants. But it depends a lot on the situation as to what kind of symptoms or how they would do.
For sure. Kathy?
Yeah. So when women get diagnosed younger, they get older if they don't have a recurrence. So now we're, lots of discussion about the ER positive individuals who were diagnosed younger, and they're now going to be in their 60s or 70s, God willing. What do you say to women of that age? How long do they need to continue worrying if they've not had recurrence yet?
So we're probably talking about, so it depends a little on the phenotype of the breast cancer. If you have obviously a really aggressive triple negative breast cancer, higher risk of having an earlier recurrence. But if you're, now 30 years later, it probably is unlikely to recur. The more common situation that you're probably hinting at is if you have a hormone sensitive breast cancer that you had in the past. Unfortunately, although the highest risk isn't what I always tell people in the first 5 years, there is residual risk through the rest of someone's lifetime. So it doesn't completely ever go away. Do I tell people to worry about it? I think that's an awful way to live life, to have to worry about something for the rest of your life. I think worry is natural, especially when you're diagnosed. I deal with a lot of women, a lot of young women who have a lot of anxiety about breast cancer recurrence, that we have to address, and we have to help people through so that they can still live a full life, and not have to worry about breast cancer all the time. If I saw a woman who is there in, further out, I probably say that their risk is certainly much diminished at 30 years out. But could I provide a guarantee? No, and I'm a pretty honest person. So as much as I'd like to say that there is no risk, I wouldn't be able to say that. But what I might tell them to alleviate that worry is that, look, if your cancer hasn't come back 30 years later, heaven forbid if it does come back, that biology of that cancer is very different than someone whose cancer came back within the first 5 years. So certainly if you're 60 or 70, I have a patient, I think, who's 80 or something, is that often when they get treatment, that often they might be someone that you might predict might die with the cancer, not of the cancer.
Great. I'm going to go to a question now, pre-submitted. Is there a benefit of having mammogram after 70? We discussed a little bit about this, but I'd like to honor the question. For women with a previous history of breast cancer, right breast mastectomy and dense breasts.
Yes. Period. Yes, I think that there is benefit. That's why we recommend it, along with obviously physical exam and things like that.
So I would imagine that their physician will tell them that they have to continue having these mammograms, correct?
We would recommend, and as I said, I don't put an age on it. I put it depends on your health, but yes, I would at 70, presuming this patient is otherwise, reasonably healthy, I would feel very confident that the answer would be an unequivocal yes at this point. But as time goes on, perhaps at some point it won't be in their best interest, depending on their health and other factors. But certainly at this point, for the foreseeable future, if I were to discharge this patient back to their family doctor, I would absolutely say they should have a mammogram every year.
Do lobular cancers get diagnosed more in the later age group, or doesn't matter?
That's a good question. I haven't particularly noticed that there's a higher prevalence in older patients, but I haven't honestly taken a really good look at that. So I'm not certain, but I don't think so.
I often find that the questions from older women are around lobular cancer versus younger women who, not in this session in particular, but in other sessions that we've had here at CBCN. But I often find, and it just now occurs to me, that older women are asking about their lobular cancer versus younger women. So I was just curious myself if there's any data around that.
I bet you there would be, but I don't know it off the top of my head. So I want to be honest about that. I think, you're right. I have seen, I think someone, one of the questions earlier was someone with lobular breast cancer. So it's possible, but I can't say, based on something that I've specifically noticed.
Okay, so I'm going to go to a question. I am 70 years old and I made the decision to go off hormone blockers because of side effects from different blockers. Are there any health countermeasures or nutritional means that can reduce my chance of a recurrence now that I am not on hormone blockers?
Yeah, absolutely. So again, this comes down to, this is a common question that people ask me, is like, what else can I do? And I already said my answer before, but I'll reiterate it. It's never a bad thing. So exercise is very helpful. Not alcohol in moderation, and good overall healthy diet, to the point. So just not being overweight. Those couple of things have been shown to decrease the risk of breast cancer recurrence.
And speaking of alcohol, where does an older person stand in terms of like where, there is, controversies, they go back and forth with how much to drink and, how little to drink. And right now the recommendation is very, very minimal. And those who have, wanting to have the social drinks and dinner drinks, what do you recommend in an older setting? Like you're 80 and they're coming out with these guidelines. What do you say to somebody at 80 about drinking once a week, or perhaps one a day?
Unfortunately, I would recommend, as the new guidelines recommend, is less alcohol is better. And also there is data for breast cancer. We're at a breast cancer. This is specifically about breast cancer, and there is data to suggest that having less alcohol would decrease your risk of breast cancer recurrence. That said, there are many people that I spend a lot of, if we talk about lung cancer and we talk about other cancers in which smoking and drinking might increase the risk. Sometimes you can make recommendations, and sometimes people know that, and at the end of the day, people make decisions about what is best for them or what they are willing to live with. So I certainly have recommended decreased alcohol in some of my women. I remember having a discussion, and she, I don't know that I really got through to her, but we discussed it, and what I learned really well from one of my family medicine colleagues was really just kind of opening that conversation and trying to understand, what are the things, where they are in that spectrum of thinking about it or not. So those are, these are conversations to be had. At the end of the day, I'm not controlling anyone at home of what they do. So I'd rather, at the end of the day, what I tell people, I'd rather you be honest with me. Like, if you smoke, if you drink, I'd rather you let me know than, hide it because you're embarrassed to let your doctor because you think I'm being judgmental. So that's my perspective on that. But yes, if someone asks me for the recommendation, they want to know, my recommendation is to go with what the new guidelines say, which is, probably 1 or 2 drinks per week.
Wow. Okay, not the answer we probably want, but we'll go with that. Bakun, let's try and get some more. We're coming to the end of our program here. So before I finish off with the pre-submitted, go ahead.
For sure. So this question is actually from a caregiver. So it's about her 81-year-old aunt who has been diagnosed with breast cancer. Sample cells were taken from the lymph nodes and they were cancer-free, but she was still giving a PET scan. And right now they're waiting for the results. So she's just wondering, what is the purpose of the PET scan? Is it to find out if there is breast cancer or if there's, cancer somewhere else? Like, why would they have done a PET scan if the sample cells were shown to be cancer-free?
Yeah. So that's a really great question. I'm glad. Thank you for attending the session and asking. So basically, if a patient has a more advanced cancer, more advanced being either larger, typically greater than 5 centimeters, or more lymph nodes involved, we want to make sure before we do surgery that there hasn't been spread of the cancer somewhere else, like the bones, the liver, or the lungs. Traditionally, in the past, we were mostly using CT scans to look at that. But there's certainly data to suggest PET scan is more sensitive. So some places are now using PET scans either as a routine or as part of a study. So that's probably the reason they're doing a PET scan, because they want to make sure that before they come up with a treatment plan, they know exactly where the cancer is so that they can decide what's the best way forward.
Perfect. Yeah, and that fits in because I think she'd said that it was a 6 centimeter mass. So perfect. Kathy?
Okay, so let's go to another question. Where can I find screening information and nutrition support so I don't have a recurrence as an older woman? I guess they want to know specifically, I guess, the best resources, I would say, and not to get, because there's a lot of confusing information out there. So what can someone do to make sure that they're navigating to the right sources and making sure that they do the best they can for themselves, especially as older women, because they're not navigating the way younger women are, and often the older women have people in their life that help them in this area as well.
Mm-hmm. Well, I think that so there certainly is information on a number of these, like the Canadian Breast Cancer Network, Canadian Breast Cancer Society, Susan Komen, which is the American site, probably has stuff, a lot of this information on nutrition and screening. The only thing I can say, to be fair, is that I don't think that there's a lot on specifically older women and what they can do. So there is limitations in that data. I also, to be fair though, I don't think that there is any data specifically on how nutrition support or recommendations would differ in older versus younger women with breast cancer. I don't think there's a difference in any of the data that I've seen. For screening, we've kind of talked a little bit about that here, which is that idea is I personally don't think that screening by, stopping screening at a certain age for someone is the way to go, despite recommendations for the screening guidelines, which also exist in the States. So that would be the only part. And I don't know that when I've looked at the literature on some of these websites that's actually come through. But I do think that looking at some of these reputable websites is the way I would go from. And, you guys are already here at a very important seminar, and I'm sure that they've got lots of good information that you can look at as well.
So, like we discussed before, in terms of accessing, a family doctor or a doctor as yourself, who specializes in individuals with cancer at an older age across the country, is there anywhere that, you can suggest somebody to go and look up where they can find a doctor that can help them in this way? Because they'll come to us and we want to make sure that do these doctors exist across our country? Do you have colleagues such as yourselves that are working in other provinces? How can we make sure that everybody understands that they could find something like this?
Yeah, that's a really good question. I actually just one added information to the previous question. Sure. I will just say I would like to give a shout out to the Canadian Breast Cancer Network, that you guys are doing great work and trying to maybe address some of the data isn't specific for older patients. So watch out for this space, because there might be some information on that in the future. In terms of engaging, a healthcare provider who's interested in older adults with cancer, certainly there are some well-established centers. If you're lucky enough to live in certain cities, like Montreal and Toronto are probably two of the biggest centers that have very well-established cancer and aging programs. One's at the Princess Margaret Cancer Center, and one's at Sunnybrook, and I think at the Jewish in Montreal. There are others of us who don't have a center but are interested. Like, I don't have a center, but I'm quite interested. And there are people in Vancouver and Manitoba who are interested. Certainly, we can help, but there's also the Canadian Network on Aging in Cancer, which is the foundation that Kathy mentioned that I head up. There are many physicians and clinicians who are interested in aging in older adults that are listed on there, and that might help to kind of identify at least a place to start who to look for.
And as people are living longer, thankfully, thanks to modern medicine, we are now going to have a lot of, especially certain age group like baby boomers around that area living longer, and they need access to this type of healthcare. Is there are there programs that are starting to build on this? Are medical experts starting to be interested in making sure that this space is well provided for?
Yeah, I think culturally there certainly, I know for the last 5 to 10 years, as I give lots of talks and stuff, and even the fact that you guys have recognized this and invited me to give this talk, I think there is increased recognition and demand for providers and interest in care of the older adults with cancer. Are there a lot of booming centers? I wouldn't say that that's the case. And I think what, our participants here can do is, I think you guys probably have a really good set of health advocates, is that maybe this is something we need to demand of our governments and funding. Funding is really the issue, is that this is not, quote, well established in the same way that having a breast cancer group and a lung cancer group is well established. So for many places, where we'd like to build these programs, there isn't the funding available at a hospital or from the government to do so. So I think that's really where the limitation is. I think the other thing in terms of things that we need to work on, and that I'm personally working on, is trying to educate our providers, both our upcoming future oncologists, as well as our current oncologists, in providing better care for older patients with cancer. It's a journey, I would say. I would say that we have definitely made strides in the last little bit, but there's definitely lots more we can do. And I would encourage people to, really think about that, putting pressure on, politicians and things to do that. But either other places, I would say, is I think that the Canadian Cancer Society and other granting agencies, they should really encourage this type of research. And really what they should do is they should have a call out for particular projects related to cancer in older patients. And maybe as donors, I know people here donate to different organizations, is maybe to make that a point to say, we think this is important. We should be doing more research in older patients. And, these types of agencies, Canadian Cancer Society, the Canadian Institute for Health Research, they listen to people who donate money. And, we need to stimulate research. And we stimulate research by putting our money where our mouth is.
And what about collaboration between an oncologist once the patient is finished treatment and the family doctor, if they're going to be handed over to a family doctor? Do you feel that there is that collaboration and that passing on the file, let's call it the file, so that the patient continues that seamless health care?
Certainly here, I would say in a lot of places, and certainly in Ottawa, we have a whole program that helps transition patients from care in the cancer center back to their primary health provider. I know that we have people that we do have some primary health providers here in the cancer center who also, work in the community to help build those bridges. Do I think that, I also think as a physician, even without that program, it is your responsibility to provide seamless care, to provide very clear instructions to the family doctor. Where I think we can do better is really that bilateral type of thing. I do think it's mostly from us to them. And to be fair, I think that's kind of across the board. If you're a cardiologist, usually the cardiologist tells the family physician this is what you want to do. But perhaps it'd be really great for us to build better bridges so that we can provide more seamless care. But to be fair to our family medicine colleagues, they're awfully busy. They're certainly not lacking for work, and they're really, really busy. And so I think, there are lots of great ideas, but we just need to engage the right partners and help them have the time to do that.
And this might be a very big question, but I'll finish off with this. In terms of care for older individuals in different cultures, without the language, immigrated here years ago, but they still live within their culture. What's the best advice that you give to the people who are going to be there for them and make sure that they are advocates as the voice of their parent?
I don't know this is what you're looking for, but I will tell you, I do encounter this situation quite a bit where and culturally I see that as well from people within my culture. I think what's really important, I think that what I can tell you is every loved one who comes loves their parent or their loved one very much. And for culturally, and many of these cultures where patients don't speak English, there's a sense a lot of people want to protect their family member from bad news, right? Bad news. Please don't tell my family member they've got cancer. There's this feeling that people are going to lose hope. I will say that certainly in my experience, and I help navigate these quite a lot, is that it hasn't been the case. I mean, I think many patients want to know what's happening. There may be an older patient, but they want to know what's happening. And I think being very open to that idea and to being, at the end of the day, it's still their health, or maybe to reflect on what you would want if you were in their place. I think maybe that's what I would say to a caregiver is, would you want to know what was happening if you were in that place? And I completely certainly understand where they're coming from. They're not doing things maliciously or anything. They really want to protect their loved one. But I've had many conversations with older patients, giving them the option to either know or not know, just let their family know. And I would say the vast majority want to know, and they take the news, a lot of them, when they're older, they realize they've had friends and family pass. They know life is not infinite. And they just want to have that information. They usually know. It's like when you have children, they know something's wrong, even if you don't tell them. So I do think that's important, something for people to reflect on, I think, in their heart, because I know it's hard sometimes to think about that, especially since you love them so much. No one wants to think about their loved one dying.
That's so well expressed. Thank you. That is very, very nice. So we're really coming down to we're done, but I'd like to allow you to say anything that you may want to say very briefly that you were not able to capture in all these questions.
No, I think that all I want people to know is that just because you're older doesn't mean, and I think most people know this, but I'll just put it out there, you deserve really great care, and you need personalized care to your health situation. And don't make sure that people see you as a person overall, and express what's important to you, because I don't think as doctors we ask that enough. So feel free to bring that up, that this is, hey doc, this is really what's important to me, to be able to play golf, or to be able to have time with my grandkids, or to be able to take care of myself. Those are really important things that people need to know, and don't be afraid to let us know that.
Thank you so much. Really, thank you. This has been a very, very nice session, and it addressed a lot of the questions, and hopefully we've been able to educate a little bit more, our audience about, being able to express yourself as an older person, and if there's loved ones that are attending as well, that there are options for them to be able to ask the questions, and that it doesn't end at any age, really. So I want to thank you again for your great participation. So moving along, after this session, you will be sent a survey to provide feedback on this session. Please fill out the survey, as your responses help us make these sessions a lot better. Our next and last questions and expert session for this year will be with Dr. Mark Bassick, who will answer all your questions about clinical trials. Information on how to register for this session will be sent to our newsletter subscribers. Sign up to receive our newsletter by visiting our website, cbcn.ca/outreach. And once again, I'd like to thank our sponsors, Viatris, Novartis, Amgen, Gilead, Merck, and Seagen. And again, thank you so much, Dr. Sue, for a very engaging session. Goodbye, everyone. Thank you for participating. Till next time.
Thank you, everyone.
Thanks, everyone, for coming.